Thanks for hanging around for a little bit. Are there any healthcare people in the group here? Any providers? Okay, one. All right, good. So I can just say a lot of stuff and you guys will believe me. So yeah, this is a story about a COVID-19 adverse event model that we deployed at our institution. It is running live. And it's way beyond just model building when you talk about users actually consuming these things for real world purposes. So I'm going to spend very little time on the model themselves. I'm going to give you the standard spiel about, here's the model, here's the data we used to build it, all that kind of stuff, and get right toward the actual implementation and the feedback that we've gotten from our users and from specifically our nurses. So, yeah, who am I? So I'm a physician scientist. I trained in medical informatics at Vanderbilt University doing machine learning and text classification about 15 years ago. Academically, I'm an assistant professor, and operationally, I'm the director of operational data science and machine learning at NYU Langone Health, which means that anytime there's a data opportunity, my group gets a say at trying to figure out whether there's an opportunity for using data science to improve our processes. This is our standard slide about NYU. You guys are in New York, so we have 350 plus locations. We happen to be #2 in medical research this past year, so we're really excited about that. A bunch of accolades, but most importantly, we're a really advanced IT shop. We've won a couple of different rewards on our IT capabilities. We're HIMSS level 7, if that means anything to anybody. It basically means that we're electronic throughout our entire institution. And what that means is that groups like myself and my team can exist in this institution because they're already thinking about the future. They're already thinking about how healthcare is going to be delivered in the next 5 or 10 years. So before I start, into sort of the spiel, I'm going to put all this in context for you about how we think about the big picture of clinical predictive analytics. The first is at the end of the day, there's an outcome that we're trying to affect, right? So maybe you have a problem like readmissions. So readmissions is a really popular topic in healthcare because Medicare and Medicaid look at your readmission numbers. If you're above a certain number, they will actually make you pay millions of dollars back to Medicare because your readmissions are too high. And so this is a real typical model. A lot of startups, a lot of companies that have built models for this task. And it's really important to understand how this model fits in the ecosystem of actually changing patient trajectory. So at the end of the day, you might have a really amazing model, right? So let's say I have a model that's sort of 90% accurate. For the technical people, we could talk about sensitivities and positive predictive values, but I'm just going to throw out accuracy. Let's just say, look, it's a really good model. And at some point, you have to get that information to somebody. This is what I call the notification channel, right? So there's some signal that flows through the system, and somewhere, someone has to see this. Someone that's empowered to act has to see this, right? So the idea would be, look, if I send an email, right, that's, hey, this person's at risk of readmission, right? It's probably not a very good channel because, providers don't check their emails all the time. So what this basically means is that we have to find some way to get this information through the electronic health record to the provider of interest. The second thing is I have to persuade them to take action, right? Because these are humans in the loop type of activities. So they'll look at the prediction, they'll look at the patient, and they'll say, I just don't agree. I don't think this patient's that sick to me. So, I'm not going to do anything. Or they're going to look at it and say, this patient's really sick, but your model, doesn't say that they're sick. They're not going to be readmitted. So I'm going to go ahead and take action, right? And the question is, well, which is the right answer, right? Your model telling you something, but the human telling you something else. So either way, somewhere along the way, right, I have to get people to take an action, right? And that's where all the explainability stuff, right, comes in too. If I can provide explanations about why a patient might be at risk of readmission, right, I might be able to persuade someone to take action. And finally, the intervention that I actually do has to be efficacious, right? So in a readmission problem, if you have somebody who has congestive heart failure, very advanced congestive heart failure, you know what? There's actually very few things you can actually do to keep that patient out of the hospital. So even though you might know they're going to come back, there's nothing you can do, really. And so at the end of the day, right, you're trying to affect an outcome, and you realize you do all these things, you have an amazing model, but you haven't affected the outcome. And then you're sort of really bummed out because you did all this work and nothing actually happened. So this is important context to remember because a lot of the things that my lab and my group talk about are things that happen downstream after the model build in terms of the action efficacy, not so much the intervention efficacy, but certainly about the action efficacy and the types of questions that we hear from people. So this model was loosely based on a Nature machine intelligence paper that we wrote early in the pandemic. My group was tasked with helping out about on a Friday and we had built our first models by Sunday. We had built about 13 models, asking the institution, look, what could be helpful? How can we help? And they had landed on sort of this first model, which was a favorable outcome model. This model actually went into clinical trial within 2 months. It took us about 8 months to do the clinical trial. Unfortunately, because not a lot of people have done this, we made some mistakes, and so the results were null. Not that it didn't have an effect, but that we couldn't see an effect in the data that we had. So a little bit, as things were progressing, especially as new treatments came out, right? Steroids, remdesivir, now there actually became a real reason to have a model to predict adverse events. When we first started this was one of the first models we built, and the leadership basically said, look, you can tell me that a patient is sick, but we don't have any interventions that we know work. So there's not much we can do. But throughout the evolution of COVID, right now we're at a point where we have things that we can do, and that's what sort of facilitated this sort of adverse event model. It really came about because the nurses had a very specific problem. At shift change, they didn't have a way of communicating with each other about how sick a patient was, because this is a disease that, some of them, most of the providers had very little experience with, and they didn't know exactly how to quantify whether a patient was sick or not. So they came up with this rubric that you see, right? So one of the hallmarks is whether you can breathe, right? How much your oxygen saturation is. And you can see that at the top, there's 3 variables for that. There's the temperature, right? How sick they are. There's how much activity can they do, and how much can they actually eat or drink. So they came up with this rubric, they came up with this point system and said, you know what, we're gonna use this to try to communicate with each other around how sick our patients are and at shift change. So they came to us and said, hey guys, we're trying to do this. Do you think your team could help us come up with a better model, a better way of being able to communicate about the risk of our patients in the future? And so toward that end, what we did is we defined more precisely, what does it mean for a patient to be sick, right? And so we defined it as this as an adverse event. So we said, well, look, if within the next 12 hours is because the nurses work in 12-hour shifts, is there going to be an ICU transfer, an intubation, right, where they put a tube down your throat, a hospice, this patient's probably going to die, so we're going to facilitate palliative types of care, or are they going to die? And we built a model. We basically picked a 12-hour period. We looked back to build the training set and the prediction window as ahead. We used patient data from March 1st to June 30th, 2020. And we had these windows around when blood draws happened, right? So blood draws would happen once a day in the morning. They would get things like your total blood count. They'd get things like your hematocrit, your glucose, your sodium, your potassium, your white blood cell counts and other things. And we ended up creating these windows of time, right? And the idea is that if there's a window where an event happened, a 12-hour window where an event happened, that was a positive case. And then we randomly sort of sample in a way to get all the negative cases. And you can see all the features that we have there: demographics, vitals, labs, oxygen support. So we created a model, and you can see some interesting things there. So being on a device, right, is probably the most obvious thing, right? If you're actually needing to have oxygen, you have a Venturi mask on, you have a non-rebreather, right? Clearly, right, you need oxygen to raise your PO2 levels. But some other things you'll see here are eosinophils and neutrophil percents, right? And so you'll hear later about how this is a little bit problematic. It's both very interesting that those are there, but also problematic. It's interesting because we didn't expect to see these. It's problematic because when the nurses go and the providers go to assess a patient, they don't see these numbers. They see whether the patient is breathing well or not, right? And there's a little bit of disconnect between what people see and what the model is producing. And we'll talk a little about what the implications of that are downstream. So we created a model. You can see the AUC curve on the right, on the left. On the right is the precision recall curve, or positive predictive value or sensitivity. And you can see, it's generally not an easy task, right? Even in the best cases, for about 30% of the population, right, we can identify 1 out of 5 times that people actually have one of those events in the next 12 hours. You can dial it back if you want to sit around 10%, right, and get around 40 to 50% positive predictive value. But we ended up on 20% risk after a lot of conversations with our nurses. So red means you're greater than 20% risk in the next 12 hours. That's about 12% of patients. And then your orange, about 20 to 10% of the time, it's about 22% of the patients. Let's talk a little about the workflow. So it's one thing to have a model, it's another thing to have people actually do something with it. So this is what it looks like. So you roll over this little column here, it pops up with this little pop-up hover bubble, it shows you the trajectory over time and some of the things that are contributing. It's showing contributors both in positive and negative directions. And this is a design issue that was completely constrained by our EHR. So this is all that we could do. You know, you might say, oh, you guys could have used Shapley values or Lime or, you know, all this fancy stuff. We couldn't use any of that. So we're constrained by what we could do. And in this case, you know, percentages are actually a little bit problematic, and we can get into a theoretical discussion about it, but basically, you don't know how large of the contributions actually are, right, when you see percentages. So you might have really small percentages that look like they're outsized contributions, but that's okay, right, because we have humans that are actually looking at these. And they're using it not for the purpose of, you know, necessarily saying, okay, well, that number looks like it should be 10% versus 20%. They're actually looking for the general overall ethos of what this patient is happening to this patient today and why they're sick. And you'll see why that's important in a second. So who are the users? So the users are rapid response team nurses. So these nurses are responsible for responding to code events, so cardiac arrests, et cetera. And one goal is to preemptively round on really sick patients so that if they do have an event, it doesn't happen on the floors. Right? We want these patients to have events in the intensive care units, in the ICUs. So one of the metrics that we follow is, are these patients having events in the ICU, or are they having events on the floor? And that's one thing that we're trying to achieve, is being able to get the teams there early enough to make an assessment so they can be transferred to a higher level of care. They monitor the score column, and they look to see if a patient is orange or red, and a bedside assessment is made, and then assessment is recorded in an Excel spreadsheet. It kind of looks like this. So this person is full code, the deterioration model fired for them, and you can see some, you know, data about them. And this is how we follow them over time to understand whether the model is effective and whether they're getting value from it. So what's the value? The value is this is automatically calculated, right? So someone doesn't have to sit around and, you know, input numbers into a calculator. There's a real quantitative assessment of risk. Physicians tend to think in terms of high, medium, and low. Here I can tell you with precise risk what this patient's risk is of going to having an event. It's calculated every 15 minutes, which is very timely. So the assessments are basically done every 15 minutes. And it's considered the most salient features involved with predicting risk. And this is really important because when you start with a big model, right, we give it everything, BMI, all this stuff, right? And we end up with about 14 features. And what that means for users is that when they don't see something they expect to see, the answer is, well, we include that in the model, but there were other features that were more predictive, and that's why you don't see them. And you'll see this conversation in a second. And most importantly, it elevates the experience of any individual provider to the experience of thousands of patients as defined by the model, right? So what this means is that you can take a nurse, you can take a provider who maybe hasn't seen a lot of COVID patients and elevate their experience to the point where they can identify when patients are sick and try to make interventions based on that. So what are the feedbacks and challenges? Well, we have some technical challenges. One is there's ongoing data shift, basically all the time at this point. So we have every COVID variant, so Delta, Omicron. We've had to revalidate the model and try to make sure it's still working in those different variants. We do have a problem now because we've also gotten really good at treating, so we actually have low positive sample of events. So there are just fewer patients that are having ICU admissions, mortalities, and other things. So we have to try to figure out how to make sure this model is still validating in the context of not having that many examples of people actually having events. Patients are vaccinated now. How's that going to affect the model? So we had to spend a lot of time sitting back and rebuilding those models with new patients who have been vaccinated just to make sure that the models haven't changed. All right, so at the end of the day, there's an experience of the model that the nurses are experiencing, right? And so one thing that they experience are certainly the true positives, right? So the patient turns red, they look at the patient, oh, you know, definitely red, definitely very sick. This is great, the model is awesome, it's working great, right? Everyone's happy. Well, not so fast, because we get some false positives where they go see the patient and said, I don't really see anything wrong with this patient, but I'm gonna see them anyways, right? Now, part of what the rapid response team does from an operational perspective is they want a model that is highly sensitive, right? So out of all the patients that have an event, they wanna make sure the model sees it, right? But the trade-off there is that you have a high false positive rate. So you might go see a lot of patients who just don't look that sick, right? And so there's always this trade-off between, well, don't tell me something that's not so obvious, but also not obvious at all. And that's where the false positives come in, because you have to train and you have to help them remember that they're going to see a lot of patients, some patients that just don't look that sick, right? But that's okay, because their goal is to identify the patients that are sick. And finally, false negatives, right? So this gets into a lot of hot water, because they'll be like, well, I saw this patient, they were super sick. Your model didn't identify this patient, so there must be something wrong, right? And a lot of this goes back to trust, right? Getting people to trust that this model is actually working and doing what it's supposed to do. In those instances, we drill deep into that case, and a lot of times it has to do with data entry. We don't have machines oftentimes that are running, on patients just collecting data passively. All this data is input into the EHR, and then our model runs on it. And that's sort of one of the sort of sticking points of these models being successful, is that people have to actually enter data for them to work. So what are some adoption barriers? Well, one is that we used to have 3 colors: green, orange, and red. And so people would say, oh man, patient's green, must be okay, don't have to worry about it. And that's actually not true, because we built the model specifically to identify patients at risk, not for use cases for which patients are actually doing well. And we learned this because we had our favorable outcome model that I said earlier, and the hospital ended up using it to identify patients that were sick so that they could think about how to staff in the next 12 or 24 hours, which was great that people were reusing something that we built, but was also a little unexpected, because we were like, well, we didn't build it for that, and there were a lot of assumptions about the kinds of patients that are being identified, and it might not be useful in that situation. As a provider, the model doesn't show escalating oxygen requirements as a factor, right? So if you start on room air, and then you move to a Venturium mask or non-rebreather, and finally you get intubated right within like 12 to 14 hours, that's something that says that this patient's super sick. And so the providers expected to see this in the data, but they didn't. And they were like, well, I don't know, this doesn't make sense to me, because I expect to see this. This is how I do it as a human, right? And so there was always this push-pull between, well, that's how you do it as a human, but this is how the machine thinks about it. This is how the machine does it. And having to have that conversation about, yes, what you do is not necessarily what the machine does, and to keep that in mind. The positive predictive value of 20% is low. It's a lot of false positives. I want this model to be sensitive. I don't want to miss anybody. And I already talked about this, but that's one of the challenges and feedback that we got. Why do my ICU patients score green by the model, right? So some of these patients actually look better once they go to the ICU. Now, why is that? Well, the reason that is because once you're in the ICU, interventions start happening. Things start happening to you to actually normalize you. So if you have a PO2, an oxygen saturation of 80% on the floor, you get intubated, they put a tube, they crank up the oxygen, now you're sitting at 90, 95, 100%, where you should normally be. So it looks like you're okay, right, if you put in the input into the model, but you're actually okay because of the interventions, right? If you take those interventions away, all of a sudden you're gonna drop back down again. So in other words, this model actually wasn't designed to be used in the ICU, and so we end up turning it off for ICU patients. Again, the false negatives, right? This patient's sick, but your model says they're green. How do you reconcile that? We have another general deterioration model that runs as well. So we have not only a COVID model, but a general deterioration model. How do I reconcile the two? Your model says this patient's red, this model says your patient's green. Which one should I use? And then why isn't BMI a risk factor? So very early on, BMI was definitely a risk factor for getting COVID and having worse outcomes. But it turns out, for those that are causal people, this gets conditioned out by all the other features that you have. So once you come into the hospital, once we know your oxygen, once we know your all your labs and other things, the BMI doesn't matter anymore. And so we have this conversation right with our users. Other comments? Well, the staff is looking for perfect predictability with an unpredictable disease. And this is something we always have to tell people, is that, look, the model's not 100%. It's not designed to be, neither are your predictions. So this is the best that we can do, with what we have. There's real challenge with reliance on invisible factors, right? So the nurses might go to the bedside and say, you know what, this patient doesn't look that bad. I don't see they're on room air, but there is eosinophils and neutrophils, seem to be elevated, but I don't really see anything. And the thing is, those eosinophils and neutrophils, which are white blood cells, might be leading indicators that something is going on internally, for which they might have an event in the next 12 hours or 24 hours. And so how do you reconcile what you see, right, as a human, with what the model is telling you, of which some of those internal things they're telling you are things that you can't actually assess? And so that's something that we're continuing to work through as to how you cognitively make this decision. Let's see. yeah, and then we have requests to remove patients that are considered low risk. And the model is actually changing now because it's most reliable with lab results, but now there's a new initiatives to say, well, we don't want to get blood every day. So now how does the model change, right? And so now it's a whole different situation. So you could argue that this model does not apply anymore because you're not getting labs every day, and that's one of the distribution assumptions that was made when we built this model. And then, like I said, a CBC is different than a CBC with diff. So diff includes the white blood cell counts, and those again are not often not ordered as much anymore because they're more expensive, and they want to decrease lab resource consumption. So see, things are changing. Even as we're building these models, things are changing operationally about the parameters of what's going on in the hospital. And so we have to be agile in terms of listening, right, to understand when this model should be turned off and maybe it's not useful anymore. Data quality issues, as I said, right, we depend on people to input this data and input this information. And so, not all the fields are required, especially when things were really crazy in Omicron. People just really didn't document at all anymore because they were busy taking care of patients. And so, maybe there are operational instances where we actually need to shut off the model because it's not being used, the data is not coming in a way that we can reliably say that it's useful. Some nursing considerations, particularly staff nurses had less experience with the predictive models, so we did not teach them how to use the model. There was high sensitivity, created challenges during the second and third waves with more false positives and less staff. So even though they wanted to be sensitive, there were a lot of patients, that weren't that sick. So they were so busy, they basically didn't rely on the model. And then it contributed more staff intensity and staff time, right, to review these false positives. So how do we enumerate these things? Well, we do, so there were some validations challenges as well, transporting a point-in-time model after a CBC count to an every 15-minute model. The model sensitivity and model positive predictive value are actually really hard to calculate, even in the face of interventions actually happening, right? So in the worst case, you could say, look, the model doesn't seem to work anymore because it doesn't identify patients that are being intubated anymore. Well, maybe that's because your model caused an intervention to happen, and that intervention was so effective that actually you don't have people that are getting sick anymore. And so we are working through a little bit about how do we validate these models under that context. So from an education perspective, we create these model fact cards. They're based on prescription drug cards that you see. If you've ever gotten a prescribed drug, you probably never have pulled this out, but it's this little piece of paper that's about this 1 by 1 inch piece of paper, and you open it up and it has all these details about the model and about the drug and what it does. So we actually create these. You can see that there's a summary, there's a mechanism and output, there's uses and directions about how to use it, what it's useful for, and when you should use it. There are warnings about risks and inappropriate settings and other things when you shouldn't be using it. And a lot of this is built into the EHR. So when we deploy the model, right, we try to incorporate these things into the model so the providers don't have to think about it. How to use the model, what does a red dot mean, what does an orange dot mean, what are the contributors to the model, and then what are some sort of frequently asked questions around O2 devices, numeric scores, how do we compare to other models that are actually running in the institution at the same time. And so these are sort of our communication channels. So even when people experience this model who've never heard us talk about it, they can click on this and sort of read a little bit about the things that are going on. But one challenge is that on the provider and the education side, a lot of providers don't know much about AI. They don't have a framework to think about some of the things that are involved in this in the same way that a drug product, we're taught a lot about drug products. So we're working on this now. There's a new initiative in medical education to really focus on answering about providing AI education to providers so when they encounter models like this, they're not just sort of, not sure where to start. They can actually ask the right questions to understand whether this is useful for their patients or not. All right, thanks for your time, and send me a message. I'd love to hear from you.
Thank you so much.